Hey all, welcome back to the Real Life Pharmacology podcast. Thank you so much for listening today. We are continuing on with the top 200 drugs, and as a reminder, go to reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great little study guide, refresher. If you've been out in practice for a little while, simply an email will get you access to that, and then we also get you updates when we've got new podcasts available, as well as other cool content too. So go check that out at reallifepharmacology.com. All right, getting into the medications today, we've got drug 101, and we are going to look at Atomoxetine. The brand name of this medication is Strattera. It is classified as a norepinephrine reuptake inhibitor. So as you could imagine, its mechanism of action, it selectively inhibits the reuptake of norepinephrine. And essentially that leads to an increased quantity of norepinephrine to do its physiological effects in the central nervous system and or in the brain. All right, when is this medication used? It's used for ADHD. So that is the primary use that you're going to see it used for. Kind of its role in therapy, or its place in therapy. It is a non-controlled substance. So typically, if patients are going to be placed on medication, usually the first-line medication, at least according to guidelines and everything at this point, is stimulants in addition to behavioral modifications and cognitive behavioral therapies as well. But if a medication is going to be used, we usually go to the stimulants first and foremost. If there's a desire to avoid stimulants, if there's risk factors that we don't want to use a stimulant for those purposes or reasons, then you might see atomoxetine utilized here. Adverse effect profile. It can cause some psychiatric changes. Aggressive behavior, irritability, for example. It does have the potential to impact cardiovascular changes or parameters, I should say. So there is some small potential to increase heart rate and potentially blood pressure. If you think about this, if it's increasing norepinephrine's activity, norepinephrine tends to be more the fight or flight type of neurotransmitter. So increasing that could potentially lead down the road of increasing some cardiovascular vital signs as well, such as blood pressure and pulse. Not incredibly often at the doses that we typically utilize, but as doses escalate, this may be a little bit more prominent there. Also, some rare things have been associated with atomoxetine. QT prolongation, suicidal ideation, for example, are a couple of kind of rare adverse effects that we may need to pay attention to as well. I will say with some of the rare adverse effects, particularly QT prolongation, seizures have been reported as well. It's typically going to be in an overdose type situation, not at the usual standard therapeutic dosages. So again, pay attention to that. Pay attention to our patients, making sure that we're using the medications appropriately as well. If the patient has some hepatic dysfunction, again, you're probably using this in younger patients and not older patients, so it's probably not going to be an issue. But if they happen to have some liver issues, you may need to look at dose reductions in that patient population. And then on drug interactions, pay attention to medications that may also increase norepinephrine. I think of SNRIs, for example. TCAs have some of that activity as well. So this may kind of have some of that additive effects to pay attention to there. It is metabolized by CYP2D6, so if you have any inhibitors there, we can potentially increase concentrations of atomoxetine. All right, now we're going to go with Zolpidem. Brand name medication is Ambien. Its classification is hypnotic or sleeper, sometimes referred to as CNS depressant as well. Mechanistically, it's a GABA A receptor modulator, and it exerts its effects by binding to the benzodiazepine site of the alpha-1 subunit of the GABA A receptor. So, as you could imagine, by binding and having that action on or near the benzodiazepine site, that's going to basically give you a very similar efficacy, I guess, profile as well as adverse effect profile comparable to benzodiazepines. With dosing, there is something specific I wanted to mention here. So we tend to want to be more cautious, particularly in females. They tend to be, at least there's some evidence saying they tend to be a little bit more sensitive to the adverse effects, and obviously as doses escalate there. So typically we're going to be more cautious in females, trying to limit that dose to 5 milligrams or 6.25 milligrams of the extended release, if at all possible there. Just like the benzodiazepines, Zolpidem is a Schedule IV controlled substance. I think that makes sense. There's risk for, addiction, dependence, and abuse. And the adverse effect profile going to align with a lot of what you're going to see with benzodiazepines like lorazepam, for example. Sedation, which is obviously probably what we're trying to do in managing insomnia. But excessive sedation, kind of that lingering into the next day, obviously, causing some risks as far as, operating machinery and things like that, where safety is of top priority there. Confusion, dizziness, and then rarely there have been suicidal ideations, as well as unique or abnormal sleep behaviors, sleepwalking, sleep eating, even patients, reporting having been in their vehicle and potentially trying to drive while they're on this medication as well. So something you really want to be careful with on patients, and definitely educate them and potentially a loved one that may be with them as well if they're getting this medication to pay attention to that and watch out for any unusual activity if they do happen to have someone staying with them, living with them, and those type of things. All right, metabolism I did want to mention because it's going to come into play for drug interactions. So it's metabolized by multiple CYP enzymes, but I will say CYP3A4 with Zolpidem is probably the major metabolic pathway that this medication is broken down on. So if you've got a medication that inhibits or induces CYP3A4, that's going to potentially raise concentrations if you got a CYP3A4 inhibitor, or lower concentrations if you got a CYP3A4 inducers. So, example here, St. John's wort, it can ultimately reduce the concentration of Zolpidem because it is a CYP3A4 inducer. And then the other drug interaction that I think is pretty important is in collaboration or combination with other CNS depressants. Opioids certainly come to mind. We've got a risk of increasing respiratory depression and obviously toxicity in combination with those, excessive CNS depressant action. And then benzodiazepines, obviously working in a similar type of mechanism, having those additive effects of sedating type medications can really be too much for patients. So be a little extra careful, maybe start at lower dosages if they're on these medications, or if we can get them off one before starting another, that's ideal. So again, be very, very careful with that CNS depressant type action. All right, let's take a quick break from our sponsor and we'll wrap up with the last medications. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, BCGP, BCMTMS, or NAPLEX materials, go check out meded101.com/store. We've got a ton of resources there, review courses, question banks that can definitely help prepare you to pass your exam. So go support the sponsor, meded101.com/store, and get some great content to help you prepare for and pass your exam as well. All right, drug 103, we've got salmeterol and fluticasone, brand names of this medication. It's Advair, also Erduo. And this is a combination medication, salmeterol being a long-acting beta agonist, fluticasone being an inhaled corticosteroid. And obviously this is going to come in a respiratory device, whether that be an inhaler or a dry powder device. So that's important to certainly remember, and I'll talk a little bit about some of those examples. Usages, typically your combination inhaled corticosteroid long-acting beta agonist is going to be used as kind of a first-line type of agent in asthma. With asthma, we have that inflammatory component, so we definitely got to get that inhaled corticosteroid on board. That's probably the most important thing. But guidelines definitely allow for the use of the combination of the long-acting beta agonist as well as patients progress through their disease or display worsening symptoms. We're going to add in that long-acting beta agonist as well. It can be used for COPD as well. Occasionally see that where typically in COPD we use long-acting anticholinergic medications and long-acting beta agonists. Those are kind of the first go-to medications that we utilize. But in some situations you may see inhaled corticosteroid used as well. I'm not going to go into the details of that, but you certainly can see them used in COPD. So salmeterol being that long-acting beta-2 agonist, that's gonna that beta-2 action is gonna open up the airways, allow for easier breathing, and then of course fluticasone is the inhaled corticosteroid piece, which is going to target that inflammation and reduce that inflammation, which makes it more difficult for patients to breathe, particularly with asthma. Talking a little bit about dosage forms, we've got dry powder, we've got metered dose inhaler, and I just wanted to lay out a few examples here of dosages. So we've got fluticasone propionate 100 micrograms and salmeterol 50. Usually the dosing of this combination is twice daily. We've also got a 250 per 50 dose and a 500 per 50 dose. So as patients are, struggling, not benefiting from what they're taking, we may escalate dosages based upon their response, based upon how frequently they're having asthma symptoms, and ultimately escalate that dose. So those are, kind of three examples of low, medium, and high dosages. Where we got the 100 per 50, fluticasone, salmeterol, 250 per 50, and 500 per 50. And again, all those dosages are typically going to be twice daily there. Adverse effect profile. One of the things I always remember with inhaled corticosteroids, and obviously this has that in it with fluticasone, is it can increase the risk for thrush. So we educate patients to try to rinse their mouth after using it. Other things that have been reported, some other upper respiratory tract infections, pneumonia, irritation of the throat, pharyngitis, that can definitely be reported there as well. Monitoring, I alluded to this kind of already. Obviously, we're going to, monitor lung function. We're going to monitor frequency of exacerbations, and we want to try to minimize that. Obviously, we're going to check out if they've been to the ER as well for, an asthma related purpose, let's say, for example. So paying attention to that, definitely really, really important in helping to assess some of our respiratory patients. I did want to address inhaled corticosteroids a little bit. With systemic corticosteroids, we generally don't want patients on, let's say, prednisone for long periods of time due to HPA suppression, osteoporosis risk, psychiatric changes, cardiovascular events, etc. With that said, the exposure of fluticasone systemically from an inhaled product is relatively low. So, some of those long-term consequences we don't worry about quite as much, especially when you consider the alternative of potentially not being able to breathe very well and having life-threatening asthma attacks. That also obviously isn't very good either. So with that said, generally pretty low systemic exposure to corticosteroids, but I will say it is something to kind of pay attention to, particularly if you have a patient that comes off of it cold turkey and maybe they're on higher dosages or something. That might be a situation where we could run into some of that HPA suppression type of issue there. So something to pay attention to, but again, something that I'm typically not crazy worried about, but rarely may come up in practice there. Drug interactions wise, really not a ton that I worry about. The components, the two medications are actually CYP3A4 substrates, but again, with systemic absorption, it's pretty low. Those drugs are just acting locally, so not something I stress about too much there. I will say one thing to look out for is beta blockers, particularly non-selective agents maybe being a little bit worse, like propranolol and nadolol. They can blunt the effectiveness of the beta agonist, so the salmeterol component, for example. So, reducing that effectiveness could potentially worsen our patient's asthma symptoms there. All right, next medication, 104, we've got Levofloxacin, brand name is Levaquin. This is a fluoroquinolone antibiotic. It can be used for multiple things, pneumonia, UTIs, diabetic foot infections, osteomyelitis, skin infections. Nice thing about it, we do have IV and PO options. So again, kind of inpatient, outpatient availability there. So that is certainly a good thing. Mechanistically, quinolone antibiotics inhibit DNA gyrase. So this is a good one to pay attention to if you're taking a board exam from a mechanism of action standpoint. Quinolone antibiotics are one of the few antibiotics that inhibit DNA gyrase, which is ultimately a bacterial enzyme that is needed for DNA replication. So if you remember DNA gyrase and associate it with quinolones, that'll probably help you get that question right on your exam there. Adverse effect profile, pretty much with any antibiotics, you could list nausea or diarrhea. But there are some unique ones that definitely come up, and there's actually boxed warnings with quinolone antibiotics. So when I first graduated 10, 15 years ago, quinolone antibiotics were used a ton, and then we found out all these warnings, and now we've kind of dialed back the use of quinolones if we can, like levofloxacin. So those serious adverse reactions, tendonitis and risk for tendon rupture, peripheral neuropathy, and you can have some CNS adverse effects as well. So that can be problematic too. One last adverse effect I wanted to mention was QT prolongation. So that's definitely a risk with levofloxacin as well, particularly in geriatric patients on a lot of medications and other meds that could contribute to that adverse effect. There is another boxed warning that I have seen come up occasionally on exams, board exams. There is a boxed warning on exacerbating myasthenia gravis. So if you have a patient with that diagnosis, that might be something to kind of pay attention to there. Renal impairment, there is dosage adjustments, so I would strongly recommend you looking at that if you see a patient's got a history of CKD in their profile. If you're using levofloxacin, definitely look at that. Oral administration, really, really important. Pay attention to metal cations, calcium, iron, magnesium, even zinc. These can potentially bind up the drug and reduce the effectiveness. So if you hear patients taking a lot of Tums, for example, which is typically calcium carbonate, or you see that on their medication list, or a calcium supplement, that's probably the most common, iron maybe even. If you see that on their profile, you got to make sure if you're starting levofloxacin, dispensing it, administering it, that we're not giving those together, because you're essentially reducing the effectiveness and potentially making the medication useless, where we're not getting the adequate absorption to treat the infection. So definitely pay attention to that. Drug interaction profile, QTC prolongation risk. I've talked about that in numerous episodes before. Antipsychotics, antiarrhythmics, TCAs, methadone, SSRIs like citalopram. All these can potentially increase that risk on top of levofloxacin for QT prolongation. And then last, on drug interactions, I did want to mention that corticosteroids like dexamethasone, hydrocortisone, they can actually increase the risk of tendon rupture, or at least they're associated with an increased risk of tendon rupture when patients take quinolone antibiotics like levofloxacin. All right, number 105 is Imipramine. Brand name is Tofranil. This is a tricyclic antidepressant. It's believed to increase the synaptic concentration of serotonin and norepinephrine in the CNS by inhibiting their reuptake. So again, increase in serotonin, increase in norepinephrine. Imipramine, it is an older tricyclic antidepressant. I can't say I see it used terribly often anymore. Originally indicated for depression. I probably have seen it more so used for pain syndromes, pain associated with neuropathy, IBS are a couple examples. So again, don't see it used terribly often, but definitely a good medication to remember, and remembering the class adverse effects here of tricyclic antidepressants. So some of those adverse effects, dry mouth, dry eyes, constipation, urinary retention, worsening confusion. Weight gain is also associated with this medication, QT prolongation as well. So definitely a big, healthy, maybe unhealthy adverse effect profile. Monitoring parameters, obviously you're going to pay attention to, if we're using it, depression, are they getting better? Same thing with pain management, whether it's IBS associated pain or neuropathic pain. We're going to make sure that's getting better. Can keep an eye on weight periodically, see if that's going up, and then obviously, if there is concern for QT prolongation, we can assess an EKG there as well. Imipramine drug interactions, I did want to mention a little bit. So it does have sedative properties, so pay attention to some of those CNS depressants, benzodiazepines, opioids, Z-drugs like Zolpidem. These can all have kind of additive effects. QTC prolongation, I wanted to mention those as well. If we add other meds that can worsen that, that can certainly be an additive effect there too. With its effects on serotonin, increasing serotonin potentially, we've got to remember that it can exacerbate the risk for serotonin syndrome, particularly if we're using other medications, other SSRIs, or maybe a tramadol, for example. Pay attention to those type of medications and make sure we aren't increasing that risk too much. And then from kind of an additive or an opposing type of issue. So if you see a bunch of constipation type medications, keep in mind that, imipramine is probably making that constipation worse. TCAs will do that for sure. Same thing with BPH meds. So if you see worsening symptoms of BPH, imipramine can exacerbate that. And probably what I see most often in practice is where you get a medication like imipramine started, and then 2-4 weeks later, patients have worsening symptoms of BPH, and we, start an alpha blocker like tamsulosin, or we increase the dose. So, again, pay attention to those prescribing cascade examples for sure. And one last one there is dementia medications. So you see imipramine started, there's more confusion, and ultimately, patient gets diagnosed with dementia, and they get put on, donepezil, for example. So those are some good examples of kind of polypharmacy in the prescribing cascade there. All right, that wraps up the podcast for today. Please do me a huge favor. Support the sponsor, med101.com/store. Tons of Amazon books, study resources, lots of links that can definitely help you learn pharmacology better. So go take advantage of that. And obviously your purchases there go directly to help support this podcast. If you enjoyed the podcast today, found some helpful tips, clinical practice pearls, please share us. Friends, colleagues, social media, trends, whatever. I greatly appreciate kind of the organic growth of the podcast from all of you guys, just sharing it with everybody, and I certainly appreciate that. You can also leave a rating review on iTunes if you haven't done that before. Feel free to do that if you've benefited from this podcast. And as always, if you got questions, comments, don't hesitate to reach out to me at mededucation101@gmail.com. With that, I'm going to sign off for today. Thank you so much for listening, and have a great rest of your day.